Okay. Okay, well, good afternoon, everyone, and apologies for my absence as I've been traveling, but welcome back. Great pleasure today to introduce Dr. Ruth Green, who I've known for many years since she started in pathology, in fact, in Manchester, and she's been a consultant for over a decade now at Salford Royal Hospital, where she specialises, well, she's a dermatopathologist, but specialises even so in granulomatous skin disease and inflammatory skin disease. So without taking any more time from Ruth, I'll pass over to her now, and I hope I'll leave it in Ava's capable hands to look after the admin. Please feel free to put things in the chat and ask questions so we get maximum benefit for Ruth's precious time. And I'll be presenting next week, I think actually on autopsy pathology, so something different rather than heme. So without further ado, over to yourself, Ruth. Thank you very much.
Oh, thank you very much, Richard, and hi everyone. Thank you, Ava, and thank you very much for the invitation. So I will just share my screen with you all. Oh, hang on. That's more successful. So hopefully you can all see a presentation. Is that right? And hopefully you can see a presentation now. So I'm going to get going. So if Ava or whoever wants to just shout if we have a problem, and there will be a chat, which I'm not going to see as we go along. So please just put any questions in there, and then we'll do a bit of a Q&A at the end. So as I say, my name is Dr. Ruth Green. I'm a consultant dermatopathologist. I work at what's called the Northern Care Alliance, which is a big trust in the northwest of the UK. And I'll show you a picture of exactly where I work. And I'm very grateful for your time over the next hour to find out all about granulomatous dermatoses. So I actually work somewhere called Salford, which is here. And it is a city in its own right in the northwest of England. And it is home to the BBC, which is our big broadcasting corporation. But it sits right next to and over the river from a city that you're probably far more familiar with, and that is Manchester, as Richard just said. And it's really nice because wherever you are in the world, if you come from Manchester, most people have heard of it for one or two reasons as per the screen. So that's where I am at the moment. So we're going to talk about granulomatous dermatoses. So they're one of the inflammatory skin conditions. But I'm just going to do a little bit of background to begin with. This is actually the same lecture as I gave to our UK residents programme at a conference back in January. So some of the cases are related to that. Inflammatory dermatoses, when we think about them, we think mainly about rashes and blistering conditions. And when we have a biopsy from a patient with an inflammatory dermatosis, what we really want to do is identify what we call the tissue reaction pattern. And then when we look at the biopsy, we look at additional findings, and particularly thinking about the distribution and the types of cells in the infiltrate, and we use those to classify the condition further. In inflammatory dermatosis, similar to some other areas of pathology.
Ruth,
yeah,
sorry to interrupt you, but the slides aren't progressing. Just want to let you know.
Oh, okay. You missed my Manchester slide then, hey? Let's try. Is this working now?
Yes, I see the slide that you're on now for the tissue reaction pattern.
Oh, okay. So there's quite a delay then. Is this, and then do you see 8+2?
Not yet.
No. Okay. So we have a
now
bit
I
of
see
delay.
it.
Okay. Let me just see if I can get it going. If not, we'll have to do it on without slideshow. Let's see. Let me just go out and come back in again. That sometimes is the best thing to do, isn't it? Okay. Sorry about this, everyone. Okay, is it forwarding back now?
Yes.
Okay, perfect. So that's working like that. If I actually go into slideshow, are we getting anywhere? Is that going forward and back?
Not yet.
Oh, so we're okay when we're just on the home screen. I think what we might have to do then is is that big enough on the screen to see properly?
Yes.
Okay, so I think, should we stick with that? I'm not sure how I'm going to, right, I think we'll maybe have to just do it like this, if that's okay. Sorry about that. See if I can get it any bigger, because for some reason it does not want to go forward and backwards on slideshow, and I don't want to waste any more of anyone's time. Let's try one more time. Any joy? That sounds like a no.
No.
No, that's okay. Anything I can do with Zoom? Let me have a look. Stop sharing. No. No, not to worry. I think if we do it like this, is this okay to be seen? Yeah?
Yes, that looks good.
Perfect. Okay, we'll do it like this. I'm sorry about that, everyone. It's this is where Salford was, which you didn't see, so it's there with further ado, but this is why you probably know Manchester. So as I say, what we think about is the tissue reaction pattern, and then we think about the additional findings in terms of the cells and the infiltrate. In some cases, you cannot come to a final diagnosis, and you shouldn't feel like you have to, or you have to pigeonhole things. So quite commonly in inflammatory skin all across the board, you can only just sort of come up with the vague reaction pattern and then a list of differentials, and maybe some things it isn't, but you can't necessarily sort of definitely come to a conclusion. Certainly in the UK and also in other parts of the world, a lot of dermatologists have very good dermatopathology knowledge. So it's always worth remembering that, you know, you're writing for someone who's also able to interpret the report. And therefore, we tend to give quite a lot of detail to allow the dermatologist to do that as well. And in terms of any inflammatory process, whether it's in skin or in other areas, it's always worth remembering that there's an evolution. So there's the evolution of the condition. There's then often a stage where you get the classic findings, and then there's a resolution, and then there may be a relapse. So depending on what time in the patient's pathway a biopsy happens, you're going to see something very different under the microscope. So again, there'll be sometimes in the pathway, if it's biopsied at the right time, you can make a diagnosis, but then there's other times that if it's biopsied, you're not going to be able to come to any sort of conclusion. When I think about inflammatory skins and how we report them, what I always say to people is we do like an 8+2 sort of steps. So the first things we do is the description, and I just always do it exactly the same for any case, starting with the epidermis, the dermis, and the subcutis. Thinking about granulomatous things, it's going to be very much dermal. Then you might do some additional tests, things like special stains, immunohistochemistry, and immunofluorescence. Once you've got the description of what you've got, you then have the interpretation stage by the pathologist. So your differential diagnosis, you might be able to say this is X, or you may have a huge differential with lots of really different diagnoses. And then if relevant, some advice. So maybe advice on next steps, advice on further investigations. Then that report goes to the dermatologist, and then they do their bit, which is reading the report. Does it fit with the clinical picture? And then that allows them to refine their clinical diagnosis. So, you know, they might say, well, what you think's top is definitely not it, but what you've got second, that fits with what I think. So let's have that as our working diagnosis. And the important thing is to always remember everything's like a working diagnosis. A biopsy is taken to test a hypothesis, and therefore things do change over time as more information comes to light. In terms of granulomatous inflammation, that describes a pattern of chronic inflammation characterized by the presence of granulomas. And the granuloma is just a localized collection or aggregate of histiocytes or macrophages. So if this is our cell, if we have an aggregate of cells together and these are histiocytes, that is a granuloma. And sometimes, like the one top left, that can be really well formed and really discrete. And then other times, like here, you've got a much more disparate and ill-defined mass of cells. Along with the granulomas and the aggregates of histiocytes, we have multinucleate cells, and that's when we have cells that have all merged together. So the cells keep the multiple nuclei of the cells they've come from, but has like one conglomerate mass of cytoplasm, and they would be the foreign body giant cells, of which there are different types that can sometimes help, but I'm not really sure how helpful that is. When we think about how to categorize things further, so I always think, if you've got two textbooks, tumours and inflammatory, you're in inflammatory, then you go to the granulomatous chapter, but how can you get things any better? And we tend to still classify granulomatous conditions based on the appearance of the granulomas. And it's a really sort of quite false classification, but it works, and it's been going on for quite some time, so it's difficult to change. And we'll go through each of those. It's always worth remembering, though, that if you have granulomatous inflammation of any type, the differential will always include infection. So, even in the ones where there isn't neutrophils or isn't caseation, we would still have infection within our differential diagnosis, because granulomatous inflammation, that's sort of one of the large causes. So starting off with what we would think of as, in some ways, the classic granulomatous inflammation is sarcoidal granulomas. And when we talk about sarcoidal granulomas, we talk about relatively well-defined or discrete granulomas composed of epithelioid cells and some giant cells. And these often contain what's called asteroid bodies or other inclusions. So they're not specific, but when you see them like this, you can see why it's called an asteroid body, because it looks like a star. That can be a pointer that this is a sarcoidal granulomatous condition. They often get called naked granulomas because there's an absence of associated lymphoid inflammation. But that is one of those things that, how many lymphocytes is enough? You will often find a little bit of lymphoid inflammation, and it still be, best categorized as sarcoidal. And that's the thing with all of these. There's sort of quite a bit of overlap, really, between the different entities. Conditions that can cause sarcoidal granulomas, things like sarcoidosis, as you might expect, reactions to foreign materials, metastatic Crohn's disease, so Crohn's disease with manifestation in the skin, drugs, and then infections, including secondary syphilis. We've got some cases to sort of present. And these were sort of a number of cases that I pulled out, which some of them had the same conditions in. And I think one of the things that was really striking about cases of sarcoidal granulomas, and both of these in the end were cases of sarcoidosis, is actually how they look quite similar across different patients. The first biopsy is a 46-year-old male, case 1. That's an incisional biopsy of the abdomen of a plaque. And then the second biopsy, case 9, is an incisional biopsy of the arm. And when we look at them on higher power, so when we look at them on lower power, we can see really here throughout the dermis, we've got these very well-defined aggregates of cells, to the point that you could draw around them with a pencil. And then when we look at them on higher power, we can see that they are composed of aggregates of epithelioid cells. And in this case, some of them do have associated lymphoid aggregates, but some of them are sort of more naked without the lymphoid aggregates. In both of these cases, we have sarcoidal granulomas. As I've said, differential includes infection, and we do special stains, which I'll come into in a minute, and they were negative. And the relevant history in both these cases that I don't think was provided with the cards was that both patients were also known to have pulmonary sarcoid. So what do we have? We have widespread sarcoidal type granulomatous inflammation. It's present throughout the dermis with negative special stains and relevant clinical history. And so both of these patients have cutaneous sarcoidosis. When we think of sarcoidosis, it's a multi-system disease, and it's characterized by granulomas in various organ systems, hence why it's so loved in exams. The cause is unknown, and there is a multitude of genetic, environmental, and autoimmune theories of why people get sarcoidosis. They can often present with non-specific symptoms. A third of patients have skin lesions at presentation, and the 30% of patients with sarcoidosis will only have cutaneous sarcoidosis. There are now multiple agents used for different both neoplastic and non-neoplastic skin conditions that are known to induce drug-induced sarcoidosis. So I suppose in some ways we're seeing increased numbers of patients related to that. These are just some pictures of sort of different manifestations. So the patients often have plaques, often, can be widespread or can be localized, can involve the face, the trunk, the limbs, and then you can get associated conditions. So this patient has sarcoidosis, but they have erythema nodosum as an association with it. Sarcoidosis is always what we call a diagnosis of exclusion. So we see that pattern under the microscope and we say this is a sarcoid or granulomatous dermatosis. Sarcoid is within the differential, but it's a diagnosis of exclusion, in particular when we've excluded infection. And in our centre, to exclude infection, if we would start off by doing special stains. We do a gram stain for bacteria, PAS and Grocott silver stains for fungal organisms, and then Ziehl-Neelsen and Wade-Fite stains for acid-fast bacilli. And Wade-Fite is just a modified Ziehl-Neelsen that can be more successful in visualising atypical mycobacteria. The next tissue reaction pattern is the one that we see all the time and kind of ignore in some ways, and that's foreign body granulomas. So this is a reaction to foreign body material where you mainly get the foreign body or the multinucleate cells. You sometimes do have to examine these on quite high power examination, and it's always worth polarizing the slide if you have a granulomatous condition, just to see if you've got foreign material. The material could be endogenous, so things like keratin or hair shafts or lipid or urate crystals in things like gout, or it could be exogenous. The classic one we see is in scar, where you see a sutured material with a foreign body granulomatous reaction. But we also see it in things like tattoo, fillers, medication, and for metallic particles. The next pattern is spurative granulomas, and these are granulomas that have neutrophils within and sometimes surrounding them. And in some cases, the granulomatous component is not well defined, and sometimes it's so poorly defined you think you're just dealing with an abscess. As in any other area of pathology, if you have lots of neutrophils, then you need to exclude infection, and we would do that again with special stains. But importantly, in this group where, because of the presence of so many neutrophils, your index of suspicion about infection is a bit higher, with microbiological investigations as well. And we always say that the special stains are helpful, but if the special stains are negative, that doesn't mean someone doesn't have an infection. That's when that's microbiology's job, if you like. So we're going to have another look at a couple more cases. And again, these patients have got the same entity, and the striking thing is just how similar the findings are. So this is a patient, it's a 50-year-old male patient, and this is an incisional biopsy from the dorsum of their hand where they had a large erythematous plaque. And the first thing to notice is the biopsy is really fragmented and friable. And in the context of skin biopsies, that usually happens if you've got tumour or you've got some very significant inflammatory process, often quite neutrophil driven. So it can be quite a good sign. And we can see here that, even on low power, we can see the main pathology is in the superficial to mid part of the dermis. When we look on high power, we can see that there's this very sort of diffuse infiltrate of cells, which again, these are histiocytes, but in another context, you'd be maybe worried about malignancy. And then in the center of them, there's these dense aggregates of neutrophils. Again, this is the same biopsy, and you can see a lot of friability within the tissue. But one thing that can often occur in this condition is you get quite a lot of associated epidermal changes. So here you can see sort of quite a lot of epidermal hyperplasia or thickening of the epidermis. And again, here we've got a really large granuloma with lots of neutrophils in the middle. And again, on high power, you can see just these dense sheets of epithelioid histiocytes with aggregates of neutrophils and aggregates of neutrophils. Excuse me. So this is a second case, different patient, and shows very similar findings, though with such a florid epidermal proliferation that's the thing that might catch your eye, to the point you'd wonder whether you're actually dealing with like a squamoproliferative condition. Again, we've got this very florid proliferation of the epidermis with this dense inflammatory infiltrate. And then here we've even got to the extent we've got a degree of ulceration. Again, when we look at it on high power, we can see that we've got dense sheets of neutrophils, partially here associated with some epithelium, but also associated with these epithelioid histiocytes. And again, we've got other areas in the infiltrate that very much look much more granulomatous, with the sort of just the epithelioid histiocytes and some multinucleate cells. In this case, the special stains were done, and they did show occasional acid-fast bacilli on the Wade-Fite stain. So this patient, these, if I had to describe everything like we have, then what would my bottom line, if you like, or my sort of one-line conclusion of what it shows be? That would be that the sporulative granulomatous inflammation with acid-fast bacilli, and that would fit with atypical mycobacterial infection. And actually, both of these patients, the biopsy was from the hands or lower arms. One patient, I think, owned an aquarium, and the other patient owned an aquarium shop, I think. And so both patients, the diagnosis is Mycobacteria marinum, and that was confirmed on microbiology. So mycobacterial infection, mycobacteria are aerobic rod-shaped bacteria. They don't form spores, they're lipid-rich, and they have long-chain mycolic acids in the walls. They're generally present in water and soil, and they usually enter the body through the skin and mucosae, which explains why cutaneous infection is common. Transmission can be very varied depending on the type. So zoonotic, person-to-person, vector-borne, or environmental exposure, which is what we're thinking in this case with infected water, which can be things like Mycobacterium marinum or ulcerans or Haemophilus, and you can catch it from various animals depending on where you are. When we think about atypical mycobacterium, the way that we tend to think of that is that means infections caused by mycobacterium, but excluding tuberculosis or leprosy. And then if you want to subclassify it further, it tends to be more based on microbiological grounds, looking at whether they're rapidly or slow growing. So we don't really do that in histology. The clinical disease that the patient develops depends on the route of exposure and also host susceptibility factors. So is the patient immunosuppressed? And infections usually transmitted via direct inoculation. So things like trauma or surgical procedure, increasingly things like cosmetic procedures that people have, or injections. But once you've got to atypical mycobacterial infection, it's generally then with microbiology that you're going to actually identify the causative agent. In terms of our cases, a Mycobacterium marinum, this is causes localized skin and soft tissue infections following exposure of contaminated water. And patients present with granulomatous lesions, often after puncture, injury, or trauma. So they've had a minor injury to their hand that they won't have noticed. Then they put their hand in their fish tank, and that's how they get the infection. It can sort of vary from sort of papules and nodules that ulcerate to what's called a sporotrichoid pattern, which is a more linear pattern of spread, which is spread in sort of along the lymphatics. And the reason that the patients tend to get them on their hands, number one, that's what goes in the fish tank, but also because the optimal temperature for growth is around 30 degrees. So that tends to be more involving like the extremities, but the patients can also get it on the tip of the nose. And I've got to say, most of the cases of this that I've seen, they tend to come with the clinical suspicion, because when somebody's got the lesions, the first thing you ask if they've got skin condition on their hands is, what's your occupation? Are you touching chemicals? Are you using chemicals? Do you have a fish tank? And if you ask the question, you're going to get the answer. So it's one of those that it is worth maybe asking about their hobbies and if they've got any pets. This is a different case of infection, just to sort of think about the different presentations from a histological point of view. This is a 9-year-old girl with a lesion on her face. And this, again, is a condition that shows really a reproducible histology. I haven't seen huge numbers of cases of this just because of where I practice, but every single one looks the same and is the sort of diagnosis that you tend to make on low power. We don't have those florid epidermal changes in this case, but we do have a dense infiltrate of it is granulomatous inflammation within the dermis, associated with some other inflammatory cells, which are obviously like the purple ones. When we go on high power, we can see that the infiltrate is granulomatous. It's very uniform across the slide, and the epithelioid histiocytes are associated with lymphocytic and plasmacytic infiltrates. And then when we go on even higher power, we can see that there's all these little tiny dots, which are the amastigotes. So the dermis in this case is expanded by a dense, almost confluent histiocytic infiltrate with associated plasma cells. There are widespread basophilic bodies, which are Leishman-Donovan bodies, and the diagnosis is therefore leishmaniasis. Giemsa can be helpful to show the bodies up, but again, I've never really found that myself. I think you can generally see them on the H&E. We then would send, obviously, a lot of it's in the history. So once this diagnosis is made, if you go back and ask history, you'll often find the patients have been abroad, and then we send it to our local hospital of tropical diseases for PCR to try and identify the subtype. So a little bit more about leishmaniasis. It's a parasitic disease transmitted by sandflies infected with the protozoa Leishmania. It's endemic in more than 70 countries worldwide, and there's just a few countries really in the southern hemisphere where it's not found. The clinical manifestation of the infection depends on the species, as well as the geographic and varies with geographical area, as well as the host's immune response. And traditionally, it's split into non-American or Old World variants and American or New World variants, and that's important based on the different clinical presentations the patients may have. So the most common form of leishmaniasis is cutaneous leishmaniasis. Lesions tend to occur at the site of inoculation, so as you would expect from an insect bite, the face and the limbs. The lesions will often slowly expand. This happens about 2 weeks to about 6 months after the bite. So in some of those, if it's 2 weeks after, people tend to associate it, like, I had a bite there. If it's 6 months, I think people would probably not. So again, like, the clinical history from the dermatology point of view is really important. And the lesions are sort of papules and nodules. They slowly expand and then they can commonly ulcerate. In a lot of cases, they may resolve spontaneously. And this is a really good example of what the concept I was discussing before about the life of the lesion. And that's that the histological findings can be very different depending on the stage of the biopsy. So if you get the right stage, you have that really classic picture with lots of granulomas. If you have a lesion that's starting to resolve, you may have granulomas, but without any of the causative agents. And later on, you may just get very vague granulomatous inflammation in an area of scarring. So depending on when it's biopsied, the clinical suspicion, the presentation can say whether you can make the diagnosis or not. Mucocutaneous variant is very destructive, and that's only seen with the American species of Leishmania, which is why that distinction still persists. But some patients, do have a more aggressive clinical course in the diffuse or disseminated variant, and that's often due to the host response, or if there's a more visceral involvement involving the internal organs. The next group, and I suppose the classic group of granulomas that we think of, are tuberculoid granulomas, based on the fact they resemble the granulomas that we would see in tuberculosis. This is granulomatous inflammation associated with caseation, and the main differential is infection. And I think one of the things that I find, and I think other people find difficult sometimes with granulomas, is you have kind of spurative granulomas, and you have caseating granulomas, and you have necrotic granulomas. And it's kind of, they're quite clear distinctions when you have a really good case, but in a lot of cases, there's quite a lot of overlap, both in terms of the histological features, but also the causes of those. So I see them more as like just descriptors of what you see under the microscope, and then think about like the potential causes, but keeping in mind that there can be a lot of overlap. So the spurative ones, like Ruth discussed, that's when you get the histiocytes with lots of neutrophils in the center of the granuloma. And the tuberculoid ones is when you get the epithelioid histiocytes around the edge. But what you have in the center is more necrotic tissue. So it's degenerate tissue, necrotic tissue, tissue's died off, there's neutrophils often, there's degenerate bits of cells. And it's called caseating, obviously, because if you cut into a large one, what comes out looks like cheese. And then the necrobiotic ones, which is just degenerate collagen in the middle, which doesn't have the associated sort of inflammation. So in tuberculoid, we're just talking about this necrotic tissue in the middle, which is which looks like, caseating, i.e. it looks like cheese when you cut into it. I'm not going to talk a lot about tuberculosis because this is not something I have really any experience of. And I think Richard mentioned you'd already had some lectures on that. But just to say that there are multiple ways that tuberculosis can present within the skin. This is a nice case, though, of a tuberculoid granulomatous condition, which isn't tuberculosis. So this is a patient, she was 24, and she had a 6mm punch biopsy from her axilla, and she presented with multiple pink and yellow papules on the face and axilla that had come on relatively rapidly, so over a couple of weeks, and then remained relatively stable when she was seen a few weeks to months later. And a biopsy was taken, and they show a very clear tuberculoid granuloma. And then we have all these histiocytes around the outside, and then we have this caseating material in the middle. And it did appear that it was adjacent to and possibly associated with a hair follicle. On higher power, we had, a classic picture of a tubercular granuloma. So the histiocytes around the edge with the necrotic material in the center. And again, as I say, it was associated with this little dilated hair follicle. In some areas, the infiltrate was almost slightly sarcoidal. So we've got caseating granulomatous inflammation, or a tuberculoid granuloma, which appears to be associated with a hair follicle with what seems to be quite a distinctive clinical presentation. Because it was tuberculoid, the first concern is infection, but all the special stains that we do, so the Gram, the PAS, the Grocott, the Ziehl-Neelsen, and the Waidefite stains were all negative. And this is a case of acne agmenata, which when you have this clinical scenario with those histological features and you've excluded infection, is the diagnosis that you come to. Acne agmenata was first described, a long time ago, over 100 years. And over the years, it's not changed itself, but its name keeps changing. So you may well know it more as lupus miliaris disseminatus fasciae. It's been called acne agmenata. And the most recent change to its name is a facial idiopathic granulomas with regressive evolution, or figure. And that's quite nice because that kind of explains what it is. It was initially thought to be a tuberculoid reaction, hence why it was called tuberculoderma of the face. But now we know that there's no association with TB. This is the clinical presentation, and it tends to occur mainly on the face, but also on the axilla, but it can just be on the axilla with these little brown, yellow papules. And they often involve the eyelids, which can be really important in the differential diagnosis. Interestingly, if you like this sort of thing, if you look back, there's been, say, 200 cases in the literature. I don't think it's that rare, it's just people stop reporting it. And even if you look back to some of the earliest cases, say well over 100 years ago, that presentation and the pictures are entirely reproducible to what we see now. So I think this is in some ways a clinical diagnosis with supportive histopathology. Again, just to sort of demonstrate the point, I suppose the histology is very different at different stages of the condition. So early on, you probably won't see any granulomas, so just a few histiocytes. You may even have some neutrophils at that stage. And then later on, you get these perifollicular epithelioid granulomas. At some stages, you just see sarcoidal granulomas. At other stages, they're epithelioid with neutrophilic abscesses, so a more sporulative picture. And then the classic stage is this tuberculous granuloma with this caseation and the hyalinized collagen. So again, if you had it at an earlier stage, you're probably going to have sarcoid top of your differential. And then once the patient's had investigations and that's not what it looks like, it may become clear, actually, no, it's acne adminata. In terms of the pathogenesis, we don't really know why it happens. There's no association with tuberculosis. It certainly seems to be associated with hair follicles. So whether or not Demodex mites are associated with it, it remains a possibility. It's been postulated it could be immune response to the pilosebaceous unit. It could potentially be an allergic granulomatous reaction. And more recently, people have wondered whether it's a form of granulomatous rosacea, but the distribution of the lesions just don't quite fit with that. So it does seem that it's probably an entity in itself, whatever name it currently has. In terms of the differential diagnosis, things we might think about are things like acne, vulgaris, things, as I say, like granulomatous rosacea, cutaneous tuberculosis, granuloma annulare, which we'll come on to, and then things we've thought about, like leishmaniasis, sarcoidosis, and other infections like syphilis. One of the sort of the final and the big groups of granulomatous conditions of the skin is the necrobiotic conditions. And that's because they're kind of unique to the skin, because by definition, they involve collagen, which is in the skin. And when we think about the necrobiotic granulomatous conditions, what we see is we see palisading or lining up or surrounding of histiocytes around necrobiotic or degenerate collagen. And they can often therefore have quite an annular appearance, whereby you have these all around here. You've got the histiocytes lining up in a ring, and then you've got the degenerate collagen in the middle. And again, here you've got the histiocytes lining up in a ring, and then the degenerate collagen in the middle. And again, what you see, it depends on the stage of the process. So sometimes the collagen is barely degenerate, and sometimes it's so degenerate, it almost your question is, well, is this necrobiotic or is it actually necrotic, and is it a tubercular granuloma? In terms of the sort of conditions that cause this, we think about three big ones, though I'll discuss one other. One is granuloma annulare, which is palpable annular lesions, often occurring on the hands, the feet, and the face. Second is necrobiosis lipoidica, so shiny, atropic, yellow-red plaques on the shins. And then finally, rheumatoid nodules, localized swelling or tissue lumps over bony prominences, and they usually or almost exclusively occur in association with rheumatoid arthritis, though they can precede the development of the arthritis. And the big question we often get is not whether it is. So the clinicians often will say this is a granulomatous dermatosis, and the big question is often, is it granuloma annulare or is it necrobiosis lipoidica? So we're going to just look at a few cases of granuloma annulare and necrobiosis lipoidica. They all show palisading granulomatous dermatosis with necrobiosis. So that's in both. But when the question is, well, which one is it? How do we decide that? In cases of granuloma annulare, they are usually in the superficial to mid-dermis, though you can get a deeper variant, whereas necrobiosis lipoidica is usually the mid to deep dermis. Granuloma annulare can have what we call an interstitial or incomplete pattern, and I'll show you a picture of that. In granuloma annulare, you often get eosinophils and you very rarely get plasma cells. However, in necrobiosis lipoidica, you invariably have plasma cells. So like we said right at the beginning, it comes down to recognizing the reaction pattern and then what's the inflammatory cells that may be associated with it and where is it and what's the distribution to allow us to make the distinction. Interestingly, in granuloma annulare, in the center, so in the necrobiotic area, if you did a mucin stain, you would find that there was mucin. And I have looked into why that is, and everything says it's from the connective tissue, which is fine, but I've not been able to find any sort of good explanation of why you would get mucin in granuloma annulare, but not in necrobiosis lipoidica. So this is granuloma annulare. It actually looks this is a 39-year-old female patient with an incisional biopsy in the axilla. And it kind of looks a bit similar at this power to our sarcoid cases, actually. But the granulomas don't seem to be quite as well formed, and there does seem to be a bit of a pale area in the centre. And when we look at them on high power, we can see really clearly in this case, it's not as like everything in life, it's not always as clear. There's palisading of the histiocytes around the edge, and then the necrobiotic or the degenerate collagen in the middle. This area here is slightly less well formed. You can start to see the cells have been a little bit interstitial, which means between the collagen fibers. So again, we can see the histiocytes around the outside. But in this case, the collagen fibers aren't quite as degenerate, so you can actually make out the fibers. This is another case. Again, this is very similar. This case, they're both actually involving quite a lot of the dermis. And again, in this case, you can see there's definitely an infiltrate going on in the dermis, but again, it's slightly less well formed. Areas like this, it seems to be, quite diffuse. And then when we look at it on higher power, we can see areas like this, where rather than forming a really nice palisading of histiocytes, you've got this sort of admixed population of cells between the collagen fibers. And this is what we call the interstitial or incomplete type of granuloma annulare. And this is really easy to miss on histology. So if you have a patient and there's something going on in the dermis, and when you're looking under the microscope and you're not quite sure what, just always think to yourself, okay, could it be something interstitial? And have a little look and see if there's histiocytes between the collagen fibers. And it can sometimes be as subtle as this, where you just have little cells admixing between the collagen. So granuloma annulare, a common dermatosis, possibly a delayed hypersensitivity reaction, and it can have a delayed, very variable clinical presentation, but it often involves the dorsal of the hands and fingers, and not frequently, but from time to time, we do get biopsies from patients with GA of the hands coming down as, some sort of non-melanoma type skin cancer. And you get 3 or 4 biopsies and all of them are granuloma annulare, because they can look like really quite tumid lesions. A generalized form does exist where patients have more widespread papules, often around the axilla and the groin. And then there are some rarer variants, so deeper subcuticular variants. You can get a perforating variant where they actually sort of come out of the top of the epidermis. Atypical variants which don't look typical, which make it hard to diagnose. And then, as I say, an interstitial variant where you don't get formed granulomas, but just a more diffuse population. Going to compare and contrast that now with necrobiosis lipoidica. So this is a patient, have I got the details? No, so this will be a patient, probably have a history of diabetes, and they've got lesions bilaterally over the shins, and the bilateral nature can be helpful again if you're trying to distinguish between whether or not somebody's got a neoplastic process or an inflammatory process. And we can see here on low power, nothing in the epidermis, but there does seem to be this infiltrate in the dermis. And it's one of those things you kind of have to sit back and believe, but in necrobiosis lipoidica, the infiltrate can often have a bit of a linear and horizontal pattern to it, as opposed to sort of a more punched out sort of round aggregates. When we look at it on high power, often you can just see, again, sort of streams of histiocytes, but in areas you will see they seem to be palisading, again, around degenerate collagen, and you can even see some degenerate elastin fibers in this area. Other areas, so it's not uncommon in necrobiosis lipoidica to get quite a few multinucleate cells, but the thing that can be really, really helpful if you're really struggling between GA and necrobiosis lipoidica is, are there plasma cells? And if you look on highish power and you easily find plasma cells, you're almost certainly dealing with necrobiosis lipoidica. So it is less common than granuloma annulare, and it's well known, I think we'd all remember from medical school about an association with diabetes. Actually, only about 1% of diabetic patients develop necrobiosis lipoidica. But if you have necrobiosis lipoidica, you probably, or a lot of those patients will have diabetes. It tends to present with papules and plaques on the shins. And in a third of cases, there will be ulceration. And that's why the differential with tumours sometimes exists. And I understand that the patient's diabetic control doesn't necessarily matter in the development of this condition. Just to sort of say, we see this infrequently, I think probably because the patients don't present to dermatology, they present to rheumatology and they make a clinical diagnosis. But classically, in terms of the third necrobiotic condition, we think about rheumatoid nodules. They affect about 35 to 40% of patients with rheumatoid arthritis, most of which have rheumatoid factor. And they're usually asymptomatic, and they're quite well defined, as you can see in the top picture, papular / almost tumorous lesions occurring over the joints, particularly in the hands. The histology shows necrobiotic granulomatous inflammation, usually in the deeper dermis, even going down into subcutis, with a really kind of dense pink appearance in the center. Now, this is supposedly necrobiosis, so necrobiotic collagen, but interestingly, in this case, it often stains positive for fibrin stains, so things like Marsh's scarlet blue. And again, I'm not entirely sure why that is. They can have associated lymphocytes, plasma cells, and also a few eosinophils, but it's usually a clinical presentation. So I think over the years, I've seen maybe only 1 or 2 cases of this biopsied, even though it's actually relatively frequent. And then the last just condition to do with interstitial or type granulomas is this one. So when we thought about the interstitial or incomplete type granuloma annulare, so the histiocytes dissecting between the collagen fibers, the differential in those cases can be this condition, interstitial granuloma or interstitial granulomatous dermatosis. So this is a condition where patients have this population of histiocytes dissecting between collagen fibers, but it isn't GA. It can, again, like GA, be incredibly subtle. And sometimes you kind of have to do the CD68 to see the histiocytes and then identify them. And what this condition is described as is exactly what it says. So if you are happy it's not GA, if you haven't got the mucin, you haven't got the right presentation, you would then call this interstitial granulomatous dermatosis. And this is a condition with very variable clinical presentation. And the relevance of it is that it is usually / invariably associated with underlying systemic diseases or drug-related etiologies. So you have a patient with a known history, usually of something else. They present with an unusual rash that the dermatologist can't quite place. They have a biopsy. It shows an interstitial population of histiocytes. You may even report it as GA, but that just doesn't fit with the clinical presentation, and therefore take a step back, just describe what it is, interstitial granulomatous dermatosis. And from a histological point of view, interstitial histiocytic infiltrate, variable numbers of lymphocytes, neutrophils, and eosinophils, and as I say, can show similar or exactly the same features of interstitial GA. And just to sort of finish, as it were, it's always worth an interstitial pattern, like I said before. So something happening between collagen fibers can be very difficult to pick up on biopsy and pick up when you're looking at the biopsy. And so we will often call that an invisible dermatosis. And if you are interested in skin pathology and do quite a lot of skin pathology, it's always worth thinking about invisible dermatoses, i.e. things that when you first look down the microscope, you think, oh, that looks like normal. And then you remember that a dermatologist wouldn't generally biopsy normal skin. And if you're ever struggling with a skin biopsy and you think it looks normal and you're not sure, sort of my tips of things to look for would be start off in the stratum corneum, so the keratin, and have a look if that's number one there, because in certain variants of things like pemphigus, it can just be absent and you can barely pick it up. And then is there anything else going on in the keratin layer? You often might see different patterns of parakeratin, or you might find fungal organisms. So if you're really struggling with the skin biopsy, just always do a PAS stain because you may well find some fungi. Always think about infection. So we've already talked about but again, like I say, do a PAS and Grocott silver for fungal organisms can be helpful. And we have immunohistochemistry in our department for treponema, so for sort of syphilis. And that can be worth thinking about if you've got a pattern that just doesn't seem to fit in, because syphilis can show anything. Things we would also think about is disorders of pigmentation. They can be quite difficult to pick up because it can be very difficult, particularly if you've only got a small biopsy, to know if what you're looking at is normal for that patient or abnormal. So again, you need a lot of clinico-pathological correlation. And if you have a biopsy which is taken after the patient's conditions is resolving, you may only see pigment incontinence, which is pigment, melanin pigment in the superficial dermis. Lymphoproliferative and hematological disorders in the skin can be very subtle. So mycosis fungoides is the most common variant of cutaneous T-cell lymphoma. And it's worth just always, if you're looking, you can't really work something out, have a look. Have you got lymphocytes in the epidermis? Have you got them in the dermis? Do they look atypical? And then the other condition to never sort of forget about in a invisible dermatosis is called TMEP, which is a variant of mastocytosis. So again, if all you've got is a biopsy with just a few inflammatory cells around the blood vessels, have a good look at those cells and just think, do they look atypical? And do I know what those cells are? And if you don't, just do a mast cell marker, because you may well find they're all mast cells. Deposits of things can be subtle, particularly pink things, because they look exactly the same colour as the collagen fibres. So amyloidosis, again, if things aren't quite adding up, is there something subtle going on in the papillary dermis? Is it worth doing amyloid stains? And then finally, as I've said, things going on in the more interstitial part of the skin. So that can be things between, so things like histiocytic things or mucin, or also things like scleroderma or elastolysis, so things affecting the collagen and the elastin fibres. And that's everything I wanted to say. So granulomatous dermatoses are a common but very varied group of inflammatory dermatoses. And the distribution and morphology of the infiltrate, as well as the nature of any associated inflammatory infiltrate, is really helpful in coming to the diagnosis. Infection should always be considered, and special stains should therefore also be considered as well. But actually, in a lot of cases, you're only going to get the answer by close correlation with the clinical presentation. So you need accurate clinical information, and it's okay to go back to the clinician and see if there's anything else. And I think the thing, to remember, like I said, with all inflammatory things, not all cases have specific diagnostic features. That's not to do with you not knowing all the conditions. That's just how it is. So it's really not uncommon to get to the fact that you've got a granulomatous dermatosis, but then not be able to actually place it any further. Sometimes you can't even categorize it because these categories of sarcoid or tubercle, it just doesn't quite fit in any of those either. And you just have to say it's a granulomatous dermatosis. I can't really get any further. I don't want to pigeonhole it and kind of send you down the wrong path. And that's as far as we can go. And then at that point, the clinicians can send things from microbiology to exclude infection, go back to the patient, have a look at the history, have a look at the distribution, and then hopefully make some more progress. And that's it. So just acknowledgements to my lovely colleagues at Salford, both in the pathology department and also in our dermatology centre, and also our trust, the Northern Care Alliance. And that's me done.
Thank you, Ruth. I know there's one question in.
Okay. Let me have a look. Shall I have a look? Hey, slides are not progressing. Thank you. Yep. I want to see the amastigote. Oh, how do you feel about, so show the amastigotes again. I can go back and show those. How do I feel about, I have never heard of that stain, I'll be honest with you. We never do it. We still do Zeal-Nielsen, and then just suggest us, we'd still just do Zeal-Nielsen and Wade Fight, and then we send things for either PCR. If you've got lots of organisms, we might sometimes send the formalin fixed tissue for PCR, but more usually, if we think there's the infection there, we would just advise them to send material to microbiology to try and identify the causative agent. So I don't have any experience of that stain. I will just go back to the amastigotes. Let me get the slide up first, and then I'll share it with you. Where were we? Nope. Here we go. I have the slide. So I will share it with you. So hopefully you can see a screenshot now. If I can make it a bit bigger, that might help. Oops, that's a bit out of focus. Okay, we'll go with this. So we've got all the histiocytes, which obviously these ones, and then these little dots here. So these little dots here, these little dots here, little dots here, sort of 5 little dots there maybe. They're all the little amistogotes. Again, over here maybe is better. So all these little ones here, and these little ones here. Though I've got to say, this is like, it's like everything when you put things in a presentation. This is a really good example. So what you can often find is that it looks a bit more like these areas here, where they're a little bit more spread out, and you would sort of find screen after screen with none, and then just some areas with them. So it's, again, it's a bit of a, it's like everything. If it's a good example, it shows great features, but they probably might well have come up with that diagnosis clinically, because ultimately we're only seeing what they're seeing clinically. So if it's a good example clinically, and if it's not a good example clinically, it can also be difficult on histology, because it's either not going to be quite typical, or it's not going to be quite at the right stage where it's presented to sort of see this typical features. Okay, so okay, so let's go for how clarify necrobiosis lipoidica. So necrobiosis lipoidica, from a clinical point of view, it tends to present as bilateral waxy plaques on the anterior surface of the shins. And then from a histological point of view, it's a palisading necrobiotic dermatosis. So we have palisading of the histiocytes around degenerate collagen. This tends to occur in the mid to deep part of the dermis. It tends to, on low power, have a like somewhat linear distribution, in that it's kind of parallel to the epidermis, and the associated perivascular, or associated with the granulomas, inflammatory infiltrate tends to have lymphocytes, but then also plasma cells, and in my experience, actually quite large numbers of plasma cells. So kind of low power, something going on the dermis. Higher power, okay, it's granulomatous, and there seems to be some sort of lining up with some degenerate collagen. And then let's look at the inflammatory cells next to it, and there's plasma cells in there. And then that's how you would generally come to the diagnosis. And if you find from the history the patient's got diabetes, you probably think, oh, okay, that's probably what it is. If you weren't sure, you can always do, I'm not, I quite like to do immunohistochemistry sometimes in inflammatory things, just to really help me see the distribution. So if I wasn't quite sure, I would just do a CD68 to look at the histiocytes, and that can really help in sort of looking at the distribution of the cells. And then that can make you sort of confident, yeah, I've definitely got a histiocytic thing. And on occasion, I've had to do that when I've sort of been like, I think they're histiocytes, but I'm not quite sure, just to make sure you're not missing like a really poorly differentiated carcinoma, because every now and again, one of those can come up that almost looks granulomatous, but actually when you do the markers, they're cytokeratin positive instead. Hope that answers your question. Let me keep going. How to diagnose granuloma interstitial variant. So in terms of granuloma annulare interstitial variant, again, comes down the same. You're going to look down the microscope on low power. If you're lucky, you're going to realize there's something vague, or there's some more cells than there should be within the dermis. If you're unlucky, it's going to look like a normal skin biopsy. So then you go through your process, look at the epidermis, look at the dermis, look at the subcutis. And when you're looking at the dermis, again, when you're kind of thinking of, well, where should I be specifically actively looking if I can't really identify anything? And that place is often at the collagen fibers, the elastin fibers, and is there anything between them? And when you do that, you'll then start to see that there's actually histiocytes between the collagen fibers. Sometimes once you see that, it's kind of obvious. And what you often see in a biopsy, if you've got a big enough biopsy, is areas where you haven't got that, and then areas where you have. And then that gives you that little bit more confidence that you're seeing something real. If it's only a small biopsy and if it's really subtle, again, sometimes it can be helpful to do CD68, and that can just really pick out the histiocytes between the collagen fibers. But I've got to say, it's one of those things that once you look for it, it's generally okay to identify whether it's there or not. And what you will often find in biopsies, particularly for GA, is that that if you sort of look and you can't really see much going on, and then you look and you think, oh, there's an interstitial area there. I think it's probably interstitial GA, or it could be. If you then start looking at the rest of the biopsy, or you then start cutting levels, you may find slightly more typical areas of granuloma annulare, and it was just you were sort of at the edge of one, or you might cut into a more florid interstitial infiltrate, and then that will make you like a bit more confident. Because if it's only subtle, sometimes you think to yourself, am I actually seeing anything here, or am I just like sort of these cells that are absolutely fine to be there, but I'm trying to make them into something because I want to kind of find something to call it. But again, you know, sometimes if it's a bit subtle and I'm not sure, I just raise it as a possibility, and I just say there's a few histiocytes, the significance is uncertain. However, I have considered a very subtle variant of interstitial or incomplete type granuloma annulare, and then the clinicians will take it from there depending on what they think. Right. If you suspect TB, but the Zeal Nielsen is negative, what do you advise the clinician? So I suppose from our point of view, cutaneous TB is sort of uncommon, but like broadening it out for atypical or TB in other organs, if you suspect, so if you have an acute spurative granulomatous condition, so loads of granulomas, loads of neutrophils, and we do the special stains and we can't find anything, in all honesty, infection is probably still top of the differential. It's just we've not been able to identify it. And similar to some of the conditions that I showed there, if you have loads and loads of neutrophils, you know, and it's all widespread throughout the biopsy, you may still only find one or two organisms when you actually do the special stains. So in those circumstances, I just say that. So I'll say that though the special stains are negative, this doesn't exclude infection. And given the histological findings, we still have a high index of suspicion. And then I would then at that point identify, advise further biopsy for microbiology, or that, you know, they can do the quantiferon test, you know, or whatever they want to do in those circumstances. And we've had some patients who present like that, and we think they probably have got something, but, you know, we can't prove it. And then we may well send them onto the respiratory team anyway, for them to sort of do a more detailed assessment and a kind of almost risk analysis of what to do about the patient, so what to do with the patient. In terms of testing on formalin fixed tissue, I did allude to it, but you can test for mycobacterium on formalin fixed tissue, but the yield is a lot less than in fresh tissue. So if you have a biopsy and you suspect infection, but you can't identify any organisms, you know, on the H&E or in special stains, I don't tend to send those for PCR, because I think the chances of you getting a result is very low, because by definition you can't even see them. If you can see a few and there's a reason why another biopsy might be a problem or something like that, then it may well be worth sending it for PCR, but with a view that if you don't find anything, that doesn't necessarily mean nothing's there. If you get loads and loads of organisms, then sending it for PCR can be helpful to identify them. However, you're not going to get susceptibility, antibiotic sensitivities or anything like that. So in those circumstances, it tends to be better still to send it for, ask them to send a separate specimen to the microbiology team. We have had, if I recall, one really good case where we had biopsy, widespread spurative granulomatous inflammation, lots and lots of organisms on both Zeal Nielsen and Wade Fight stains, but a sample that had been sent for microbiology was actually negative and didn't grow anything. And in that case, we sent it for PCR, and the patient had Mycobacterium haemophilum. And actually that only grows on, I think, blood agar at a certain temperature. So it's always worth just remembering as well that, you know, it can be helpful to do the two together if you can, but if you haven't got any organisms, you're not going to be able to find anything. But that can be quite helpful. And it was helpful in that case, because then they could change the growth medium that they were using, and then they could grow Mycobacterium haemophilum, and then they could get sensitivities. I hope that answered your question. Sorry, I gave a long explanation. Kinetoplast, I don't have any experience of. Okay, cutaneous TB, again, I don't have any experience of cutaneous TB per se, because we just don't see it. I think most patients who present with cutaneous TB in the UK are probably going to have respiratory TB as well and have it as a secondary manifestation, and are therefore going to get managed by the respiratory team. But I think everything I've said probably still applies. Let's have a look. Xanthogranulomas. Okay, so xanthogranulomas, that's a really interesting topic. And interestingly, xanthogranulomatous conditions tend to get classified along as histocytic disorders, but thinking of them more in terms of like neoplastic, even though they're not necessarily always neoplastic conditions, as opposed to sort of granulomatous, where we think of them more inflammatory. And again, xanthogranulomatous disorders tends to be, from a histological point of view, you get the classical features of sheets of histiocytes within the dermis, often foamy, so very pale cytoplasm, and generally with a history of a lesion. And when you then raise that as a possibility, then the clinicians will go, so you would say it's, you know, could be a xanthogranulomatous process. Obviously, the typical one being juvenile xanthogranuloma, but there've been a whole spectrum of clinical presentations, and then it tends to be for the clinical team to go and look at the patient and then decide exactly what they think it is. And the things in terms of, well, why is it xanthogranulomatous other than granulomatous? The main thing tends to be that you have from our experience, like a solitary lesion, and it very much presents as a lesion, as opposed to a sort of more diffuse inflammatory process. That said, you know, you can get granulomatous things, as we discussed, where it's a single lesion, so like the lesions on the hands. And then sometimes you can't quite make that distinction. So you almost have to say, you know, this could be a xanthogranulomatous condition, or it could be a granulomatous dermatosis with xanthomatized cells. And sort of typically, very xanthomatized cells in the granulomatous dermatosis isn't very common, outside of maybe scenario where you've got things like exogenous material. So if a patient's had maybe something topically applied, or some sort of cosmetic filler, or some other sort of procedure where there's some sort of lipid type material, then it could be xanthomatous. But again, you're going to come up with that from the history. So yeah, sometimes we can't quite make this distinction. So we just, again, like leave it back to the dermatologist exactly what, how that patient's presented, and that could be really helpful. I got through everyone. Yeah, I think that's all the questions. That's probably the end of today. I think we were an hour, and we've been with my IT problems about an hour. So apologies for the presentation, and I hope it's been helpful. If there's any questions, I'm sure you can get in touch with me if that's okay, or you know, or via Richard, as I say, I know Richard well, so I'm sure he'll be able to pass on any questions or anything else.